So welcome everybody to July's BARHII Data Committee meeting. We're really appreciative to have you here. We are going to start with introductions. So it would be great if you could mic up and let us know your name, your organization, and maybe what position you're in. So for example, I'm Melanie Newcomb. I'm with BARHII. I'm the membership liaison. I help get people into BARHII's programs and figure out where they fit into our organization. I also help coordinate the data committee along with our excellent co-chairs, Mylene Acosta and Beth Armentano. Both of them have been extremely busy, as I'm sure you all are, but it's great that we could have you here, and it's great that we can have Mylene here. So thank you, everybody. You're next.
Hi, this is Emily Way. I'm with the Office of Health Equity in CDPH.
Hi, Emily.
This is Matt Byers. I'm an epidemiologist with Alameda County.
Hi, Matt.
And it's Mylene with Solano Public Health.
Hello.
Hi, this is Eva Weinstein, and I'm an epidemiologist with Napa County, and I apologize in advance. I mean, I'm going to have to get off relatively quickly to go to another COVID meeting. Thanks.
This is Araceli Tamayo from San Mateo County.
Hi, I'm Rachel. I'm a new Cali YS fellow at Alameda County right now.
Welcome. Great to have you with us.
Hi, this is Anandi Sajir. I'm from Santa Clara County Public Health Department. Again, I have to apologize too. I might have to get off quickly for another meeting, but I thought I'll join in at least to listen to the first part.
Perfect. Sign of the times, I think, with everyone having to rush to COVID meetings.
Hi, this is Patricia Zialski. I'm with the City of Berkeley epidemiologist here. And I too will have to leave right around 3 p.m. Apologies.
Okay. It looks like we have
Hey, Patricia. I was just going to say hi to a friend. Hey, Patricia, how you doing? Remember me from the soccer field?
I know. I recognize your name. It's great to see you again.
Yeah, you too.
Anyone else? I see Meredith. Yeah, Meredith and Rachel.
Hi, sorry, this is Meredith Millette from the Office of Health Equity at CDPH.
Thanks for joining us, Meredith. Okay, yeah, so why don't we get started? So today we have Peter O joining us from the Office of Health Equity at CDPH. It sounds like we have a few members of the team here with us, so thank you all for being here. Peter is going to be presenting on state updates from the state COVID response, ethnicity and race data, as well as age data from the current response. We've actually had Peter here a few times now, so thank you, Peter, for being so willing and being now a good member of our data committee team. But we're trying to really keep the group updated on what's going on with the state and the numbers. We know you're all really interested in that, and so we want to keep you appraised and updated of where things are. So I think I'm going to go ahead and share the screen, and then we can hop right in. So let me, this one.
Great, thank you. Thank you, Melanie. I wanted to start, given that several participants have to leave in a few minutes, I want to encourage everyone to contact me if you have any specific kind of questions about state level data or a comment about the way CDPH presents and highlights its data on the tools I'm about to kind of draw from for the next few minutes. Please feel free to reach out to me. I have my email address as well as my phone number, where I'm happy to take any calls from folks who are not able to stay for the whole time today. So good afternoon. I'm Peter O with the Office of Health Equity in the California Department of Public Health, CDPH. Thanks again for the opportunity to be here with you all again today. A lot has happened since I last was at this meeting and presented on it back in the middle of May. We've had a difficult reopening of the state. Social upheaval as a persistent specter of racism resulted in the deaths of citizens at the hands of law enforcement, and a worsening epidemic. And it's been a real summer of discontent at many levels of society, and at many levels of public health and public health advocacy. And so with that, next slide, please, Melanie. And with that difficult backdrop, what I'll do is I'll provide a state-level summary of the current situation of disproportionate impacts of COVID-19 in our state by racial and ethnic group, as well as age groups at the same time, using the race ethnicity tables that are updated daily on the CDPH website. I'll say at the outset that although my office, the Office of Health Equity, has numerous staff members who are currently or have been redirected to assist with the active COVID-19 data response, the surveillance portion of it. The data I'm about to present are those being received and processed and reported out by my CDPH colleagues in the coronavirus science branch. And so I'm essentially a messenger and sort of a communicator of the data that those colleagues in CDPH are producing. Next slide, please. And please feel free to stop me at any time if you have any comments or questions, particularly given that some participants will have to leave earlier. So, as of July 19th, we have nearly 392,000 cases of COVID-19 reported in the state. Put another way, nearly 1 in 100 Californians have been diagnosed with COVID-19. That's an astounding fraction. Of the reported cases so far, nearly 7,700 have been fatal. As this group is well aware, COVID-19 outcomes are affected by forces including structural racism, poverty, and the disproportionate prevalence of underlying conditions such as heart disease, diabetes, asthma in communities of color. As the page on which this daily data chart on the CDPH website states, CDPH has a commitment to health equity, and collecting and reporting data on race ethnicity provides important additional understanding for informing action. And so only by looking at a fuller picture, by looking at data by race ethnicity, as well as by age group, as we'll do in a second, we can understand better how to ensure the best possible outcomes for all Californians. Next slide, please. So before I walk us through the state data tables, it's important to say a little bit more about the fullness of the data picture from the perspective of data completeness. And I gave this same disclaimer in my May presentation that the data on cases of COVID and deaths that I'm about to show and talk about, for data on cases are still missing race ethnicity information for over a third of all cases. And this is due to laboratory reporting practices that necessitate labor and time-intensive follow-up with providers and reporters of the data, health departments, to ascertain race ethnicity information. And so CDPH staff are working diligently to collect and catch up on this data collection effort as quickly as possible. Since there are a substantial amount of missing race ethnicity data for cases, I will not focus as much on the case data as I will on the deaths data. And the deaths data has 98% completion in terms of race ethnicity data. Next slide, please. And I'll also say that I intentionally am showing these tables on from the CDPH race ethnicity data page intentionally just the way they are. I'm not taking away from them or adding anything to them, aside from the kind of the explanation and the drawing the key points from the table, of course. But that's unintentionally. I think it's important to look at these data tables, even though they're not super exciting in terms of data visualization. I think they give us a good opportunity to look at the actual numbers themselves, which is important, as well as the percents and the disproportions relative to the state population numbers. So this is where we stand as of July 19th. For those of you less accustomed to looking at this set of data tables, I'll just walk everyone quickly through the structure of this table. The numbers of reported cases and deaths are shown in the columns by race, ethnicity category in rows, as well as column percentages that the numbers of cases and deaths represent. And the rightmost column of the table is the estimated percentage of the total California population represented by each race, ethnicity category. And this allows an at-a-glance comparison of how proportionate or disproportionate the racial and ethnic contributions of cases and deaths are to the population representation. So we see in that first row there that 44.8% of all reported COVID-19 deaths are in the Latinx population, which is disproportionately high relative to the population representation of 38.9%. That's how you would read that table. And again, focusing solely on the disproportionate impacted populations here, we see in the fourth row that 8.7% of all reported COVID-19 deaths are in African Americans in California, which is disproportionately high relative to the population representation of 6.0%. Moving down to the third to last row, among Pacific Islanders, 0.5% of deaths compared to 0.3% of the population. Before we leave the slide, I want to at least verbally address some of the key findings that my team had, and appreciate Emily Way's help with this. Emily's on the call. She's on my team in the Office of Health Equity. I should take a look at the county level data on the various local health jurisdiction websites in the Bay Area, especially because the focus of this particular group. And I just wanted to point out that there's some there's a variation in the racial ethnic disparity in COVID mortality across the Bay Area. Just a couple of highlights. So in Alameda County, where Latinos, Latinx population represents 30% of deaths compared to 23% of the population. African American deaths in Alameda are 23% of the total deaths in that jurisdiction versus 12% of the population. So we're seeing what we're seeing at the state, we're seeing in places like Alameda County. And San Francisco, just to pull out another example, it's a little bit different. We're seeing 18% of deaths there among Latinos compared to about 15% of the population representation, contrasting that to the African American percentage of deaths in San Francisco, which is 10%, twice as high as the 5% population representation. Solano County, which I know we have some representation here in this meeting, is different still, where the Latino percentage of deaths, 25%, is roughly in line with the population representation of 27%. But if you look at the Black population in Solano County, there is a strong disproportionate impact, 32% of deaths there compared to 15% of the population. So that's a couple of highlights that we looked at that just emphasize the great variation even across the Bay Area in these disproportionate impacts we're seeing at the state level, which is the focus of my presentation. In terms of the local health department data pages on the Pacific Islander community, we're not seeing that, at least my team has looked at the Bay Area counties, the web pages have not elevated an impact, disproportionate impact on the Pacific Islander community in the Bay Area counties. But then again, not all Bay Area counties had their race ethnicity data posted. So perhaps my remarks there, which are not reflected in this slide, will be the cause for some discussion or questions later on at the end of my presentation. But for now, I'll go to the next slide, please, Noreen. And so let's take each age group from youngest to oldest. This table shows only data for children under age 18. And we see here that no deaths have been reported to date in the state in this age group. And that's pretty much the only good news in this table. Of the now more than 22,000 cases with known race ethnicity data among children, Latinx children have been impacted quite disproportionately relative to their population share. So 68% of cases among children are Latinos, compared to 48% of the population in this, the population representation in this age group. And so that's pretty eye-opening, and I expect that there'll be some discussion and questions about this. Some factors that could explain this disproportionate impact of COVID cases in Latino children include the greater chance of exposure to essential workers in their household, for example. You're probably all pretty familiar with the fact that Latino workers comprise a disproportionately high share relative to their population representation in a number of essential work forces, such as farm workers, workforce segments such as farm workers, construction workers, cooks and food prep workers, truck drivers, etc. And so that exposure to essential worker adults in a household, that could be a substantial, could substantially impact transmission to Latino children. Crowded living conditions, multi-generational households are also other factors that could make physical distancing and isolation difficult in the Latinx population in California, as well as I alluded to earlier, the higher prevalence of chronic conditions such as diabetes in its population. Next slide, please. Now let's look at the excuse me. Let's look at the adult age groups. In this 18 to 34 age group of young adults, we see continuing evidence that the Latinx population is strongly disproportionately impacted by COVID-19 cases and mortality. 63% of deaths are in Latinos, in contrast to the population representation of 45%. We also see that the 15% of deaths in African Americans contrast to the population representation of 6.5%. Although, as interestingly, as you see here, the case report impact in the African American communities in this age group are not out of proportion to the population representation. 3.9% of cases in this age group are African American versus 6.5% population representation. Interested to hear what your interpretation of that is. It may have to do with testing issues not reaching this particular stratum of the African American population. Going further down this table, 2 of the 93 deaths in this age group are Pacific Islanders. That is 2.2% of the deaths in the population. That represents 0.4% of Californians in this age group.
Do you know for the about 1/3 of testing that's not coming through on the cases numbers, do you know if it's mostly from the bigger, like the Quest Diagnostics or those groups, or who's not reporting?
Good question, Melissa. I should have specified this. I don't believe it's necessarily, actually I don't know. The short answer is I don't know if the missing cases the missing case data are disproportionately attributable to certain type or of laboratory. I didn't mean to imply that we will not have those data. It's just that in terms of the cases reported to date, there is a time lag in getting that information, essentially. And so if we were able to bring down the numbers of new cases that we're having reported on a daily basis, I think the last day we had over 7,000 cases reported from one day to the next, we'd have an opportunity to catch up on the data collection. So long story short, the data are there, just they're not reported initially in terms of race ethnicity, and so staff have to actually make calls and make inquiries to fill in those blanks. But to answer your question, if certain labs are are more likely to not report the data. Actually, I don't know that information.
Okay.
So we're on slide 8. Now we're moving a little bit further along in the life course. We're now in the adult age group of 35 to 49 years of age. And again, you'll see the pattern. You've probably noticed the pattern already. We continue to see that the Latinx California population is being disproportionately impacted by mortality. 77.9% of deaths, that's more than 3 in 4 deaths in this age group occur among Latinx persons. Interestingly, in this age group anyway, a disproportionate impact is not seen for African Americans, as you can see in that fourth row of data to the right side, 5.7% of deaths compared to 5.9 of the population representation. Next slide, please. Looking at the next age group, adults of middle age and approaching the retirement years, 50 to 64 years old. We again continue to see the pattern of disproportionate impacts of mortality, which is falling most heavily in Latinos, and also to a lesser extent on the African American and Pacific Islander populations. I say the burden falls most heavily in Latinos because 65% of all deaths in this age group are in the Latinx population. That is double the population representation of 32.2%. The data also suggests the disproportionate impact on African American communities in this age group, although it's less pronounced, 7.2% of deaths versus 6.4% of the population. We also see some evidence that the Native Hawaiian Pacific Islander communities at this stage of the life course are also disproportionately impacted. The 10 deaths in this group represent 0.8%, as you can see, in contrast to the 0.4% of the population representation. Next slide, please. So in this 65 to 79-year age group of Californians now in retirement age, or perhaps we can call it middle, older age, I think some people call it, we see that deaths among Latinos continue to be disproportionately high. This is a picture that's really become very clear in the last couple of months of data collection. More than double of the population share, in contrast to 46.9% of deaths to the 21% population representation. Among African Americans, the share of COVID mortality, which is 10.2%, is also nearly double the population share, 5.5%. And again, a similar picture persists for deaths among older Pacific Islanders in this age group, although the numbers are as small as you can see in this table. Next slide, please. So in the last age group, this is the oldest, old 80 years and older, the last stratification offered in the CDPH data tables. Again, deaths are disproportionately high in the Latinx population. 30.9% of deaths compared to 19.6% of the population. In the African American population, we also see a continuing disproportion, 8.3% versus 4.8%. And again, Native Hawaiian Pacific Islanders exhibiting what could be a disproportionately high number, 0.4% of deaths compared to 0.2% of the population. So in summary, in the attempt of kind of drawing this data table summary to a close and engaging your questions and our discussion. So in summary, here's how the racial ethnic disparities in COVID-19 play out by racial ethnic group. So among Latinx Californians, that group is impacted by the highest numbers of cases and deaths. They carry the largest burden of COVID-19 in this pandemic. Latinx Californians account for 2/3 of cases among children, as we saw. Again, as walking through the table by age group made clear, cases and deaths in the Latinx population in California are in substantial disproportion to the population share across all adult age groups, and the disproportion in deaths is highest in age groups spanning prime working age through middle old age of 79. Next slide, please. For African American Californians, deaths are disproportionately high across most adult age groups, including young adults, as well as older adults 50 to 64, particularly that disproportionately strong in African Americans of retirement age and older. Native Hawaiian Pacific Islander Californians, also similar pattern, deaths are disproportionately high in most adult age groups, and the impact is strongest in age groups 50 and older. Next slide, please. So, racial ethnic groups can be disproportionately impacted across a number of health equity dimensions. So that personal level factors such as pre-existing health conditions could lead to, associated with an increased risk of COVID-19 severe disease and mortality. Demographic and socioeconomic factors, such as lower access to health insurance and care, and that could include lower access to COVID-19 testing, let's say, as well as income security and poverty related to that, job insecurity, and importantly, the inability to work from home. Those are all factors, those are all dimensions that in which racial ethnic groups that I presented on are disproportionately impacted, and that could help explain some of these strong differences and disparities that we're seeing. Essential work, I alluded to this earlier, that the essential workforce are predominantly, or disproportionately, I should say, workers of color, and so that's definitely impacting this pandemic. Crowded housing, multi-generational households, also factors, as well as medical mistrust and incarceration issues that are not addressed directly in these data tables I've just summarized. Next slide, please.
Did you say the incarceration is or isn't directly addressed in these numbers?
No, I didn't. Well, I did not address. Again, I presented on what we have on the CDPH website, which are statewide numbers by race, ethnicity, and age group, looked at together. But we don't. Our current data stratifications and our data tables don't have these breakouts by, let's say, incarceration or essential workforce. So, yeah.
Thank you.
Recognizing on the slide that those are important factors that are driving the disparities, the racial ethnic disparities that we're seeing, but they're certainly not explained by the data tables that we have published to date.
Oh, I see. Okay.
In the next slide, I just wanted to recognize that even though today's focus of this short presentation has been on racial ethnic disparities, there are numerous other state data sources that I wanted your audience to be aware of. There are numerous county level data visualizations and data tools on the California state site that I linked here. They include basic demographics of cumulative cases and deaths, new cases and deaths by county. However, the big drawback is that when you look at the county data, the county-specific race ethnicity distributions are not available, and so that's one of those. It's one of the main limitations that I see in terms of the data that we put out into CDPH. We have a lot of those data, but for a lot of kind of administrative restrictions and a history of being cautious about perhaps overly cautious about presenting data that may either identify somebody in a small population or may not be a statistically reliable estimate, again, in a small population. So I just wanted to recognize kind of the elephant in the room that CPH data sources, even though I think they are very informative and they have county level data for lots of different dimensions, such as the one I just mentioned, but the county specific race ethnicity data is currently not being shown. And I want you to know we are working on that internally to try to change that, to try to add race ethnicity stratifications to some of the county specific estimates that are shown on our website. And so I'll report more on that issue to come, hopefully, if we can make some progress. At the moment, I'm pointing out that that's a pretty major limitation in terms of being able to see the geographic differences in the disparities, which I've only been able to speak on at the state level. There are also, just to round out this slide, there are also some interesting and really informative data tools on cases both among patients and healthcare workers in skilled nursing facilities, for one. Again, I believe those data sources show data by jurisdiction and by specific facility in some cases, but again, not by race, ethnicity, or some other key demographic factors that could really help us understand the disparities better. Also wanted to let you know that there's a mathematical modeling and forecast page on the California site that uses existing mathematical models used by experts across the country and around the world to try to forecast hospitalization deaths. Again, these forecasts are also available by county, but there are no race, ethnicity specific forecasts available in those tools. So kind of what I'm getting at here, I didn't make this super clear on this slide, but kind of the bottom line is the race ethnicity data currently on the CDPH website is only available at the statewide level, which is what I presented on. And so I'd like to hear kind of your thoughts on that. I think I know what some of your thoughts are on that topic, actually. But I'll save some of that for the discussion. I did want to finish in the last slide by acknowledging my colleagues Crystal Raymond and Emily Way. I think Emily was on the phone. But also, in particular, the coronavirus science branch staff who are working hard to make these data possible and publishing them in a timely way. And I'm happy to take any questions and engage in the discussion now. And if there are other questions or concerns raised that we don't have time to discuss here, I'm happy to take them by email or by phone, as you can see on my contact information.
Just as a note for the group, we will be getting out those resources and the slides following this presentation.
Thank you, Melanie. Peter, I'm wondering if we could have a Bay Area report. And in particular, we've had a request from from a couple of African-American community groups about having a Bay Area report on what's happening in the African-American community. And I wonder if at that level of geographic cut that it would be possible, even if it's not possible county by county.
Sure. I'd be happy to do that presentation, Melissa. It's interesting. So when I gave that kind of verbal summary of what my team looked at in terms of the Bay Area County data, I recognize the irony that here we are at CDPH, and then we're looking at some of the county data to get a better idea of the data picture in the Bay Area counties, because we have those data, at CDPH, just they're not reported out yet in a way that's really efficient at this time. So I think that would be a very timely and very very focused and regional look, and I'll rely on what the coronavirus science branch could kind of, I'll have to work with them to see if we can get data directly from CDPH, as opposed to going out to the county sites and having to aggregate those data together, especially recognizing that I noticed that some of the Bay Area county sites do not have the race ethnicity data posted, and so I'm being a little long-winded. I'm saying I'm happy to do that presentation. And I have to work with our CDPH Coronavirus Science Branch folks to try to make that happen in a more efficient way.
Okay.
And I'd be happy to speak more with you offline if that's appropriate in terms of the details of that presentation, Melissa.
Sure.
Would that be okay, or would you like to discuss
That'd be
it here?
perfect. Yeah, I'll send you some times.
Mm-hmm.
Okay. Great. Thanks. This was really helpful. Were there other questions for Peter? I'm really struck by the Latinx case numbers. I mean, I had known that there was disproportionality, but it seems very, very high. Did I see somebody about to speak?
Hey, this is Araceli, San Mateo County. I had a question about whether the state has done any analysis on testing by race ethnicity. I know that the data, there's even more missing for negative tests. But since estimates are that we have about 10 times more cases than we are identifying, I was wondering if we are testing certain groups but not others, and identifying cases in some groups and not others. And the deaths are great to look at, but for cases, if there's really just been any analysis on testing.
Yeah, that's a great and timely question. As far as I know, even though the testing efforts have been rolled out by what's called the California Coronavirus Testing Task Force, which was, as of a couple of weeks ago, was co-chaired by our CDPH Assistant Director, Dr. Charity Dean, but she left CDPH, she left our department just a couple of weeks ago, and so I believe that the leadership of that Coronavirus Task Force is under some transition. It was initially a collaboration between CDPH and I think Blue Cross or Blue Shield or something. So I do know, I'm aware that as they have ramped up the availability of testing to reach more California communities, including low income and more rural communities, they've taken on equity of testing as an intentional kind of goal. And so, in fact, one of our Office of Health Equity staff members has volunteered to step forward in what's called an equity work group as part of that testing task force. So our hope is that clearly, because equity, there's a great overlap of equity with racial ethnic group in California that we've seen in the death data, we do expect to have a say in being able to collect and report on data specific to race ethnicity when it comes to testing. But at the moment, I believe, again, I'm not directly involved in the testing task force. I don't believe that, I'm not sure to what level that those data are even being collected. And I wonder if anyone else on the call has some clear information on that. But I wanted to just emphasize that we do have equity representation starting very soon on this equity work group within the larger statewide testing task force. If and when data on race ethnicity for testing specifically become available, I'll be sure to share that with this group. Anyone else from CDPH perhaps on the line who could maybe speak to the testing data aspect a little bit more clearly than I can?
I can't, sorry. I feel like there's a lot of questions running through my mind that I don't know the answers to, that I've only just done a few shifts with the coronavirus science branch, so I don't know all the details about what information we get on testing that is negative.
Thanks, Meredith.
There was another question that came through on the chat, it looked like.
Yeah, so The chat is wondering what % of racial ethnicity data is unknown, and are there any numbers or percentages for pregnant women or infants of less than 1 year of age?
So in terms of the data on cases that I just presented on, we do have 36% missing data on race ethnicity that still needs to be collected. In terms of data for pregnant women and infants 1 year of age and younger, I don't actually recall off the top of my head if pregnancy is one of the characteristics that's recorded in the this events report form. So I'll have to get back to you on that question. In terms of the infants under 1 year old, those age data are collected in every COVID case. However, I'm not aware of any reports that are specific to newborns. So I'll have to get back to you on that as well.
Any other questions from the group? Feel free to type them into your... Oh, go ahead, Melissa.
I have one more, which you may not be the right person to direct this question to, but I'll ask and it's fine if you don't know. But I'm wondering if there's any way that the contact tracing data is rolling up to be data that is useful at the state level. If there's any mechanisms for that.
As far as I know, Melissa, that's a great question. As far as I know, the contact tracing efforts are, because they're still, you know, in the phase of being set up, essentially. I don't know if certainly they've already collected substantial amounts of data, but I really have no idea at what level of readiness that the contact tracing data systems are in terms of being able to produce data. So do you have a specific question that you wanted?
Yeah, I mean, I'm wondering if there's a way that it can be useful for understanding what policy interventions might be helpful. So for example, if what we're hearing, so I guess the other question would be, is there any industry data that's rolling up about particular kinds of workplaces or things to focus on that would be helpful from policies that might help reduce transmission or might help understand where workers are going to need more support in terms of paid leave and making sure that those things fit for the industries that are most at risk.
Yeah, again, that's a really insightful point. So one thing I can say about that is I don't know of any industry-specific data on that. What I can say is that one of the ways that the Office of Health Equity has really tried to help the COVID-19 response and recovery wherever we can. You know, as you can imagine, we're kind of an upstream oriented program within CDPH, you know, social determinants of health, environmental determinants of health. In these really kind of downstream focused pandemic times, you know, it seems like we don't, you know, what we have to say is, you know, takes longer to implement and takes longer to see the fruits of. But one kind of tangible way that our office has really tried to have an impact now and in the immediate future is we've successfully applied for the use of about $850,000 of federal emergency funds that were announced sometime back in May, around the time that I gave my last presentation, actually, from the feds to fund projects that address health equity and try to assure equity in COVID-19 response and recovery efforts. And so, recognizing that the Office of Health Equity is, you know, such a small unit, we can't do that work ourselves. What we decided to do is we applied for, as I said, about $850,000 total to support 8 different projects. One of those projects includes, I believe it's about $150,000 grant to the Public Health Alliance of Southern California to provide guidance to local health departments to protect the health and wellness of vulnerable populations during COVID-19 response and recovery. And I believe that contract addresses some aspects of trying to identify which essentially workforce sectors, like higher risk industries, that vulnerable populations in local health departments, local health jurisdictions, I should say, are engaged in, and trying to address early interventions to protect the health and wellness of those vulnerable communities at the local health department level. If folks on this call would like to hear a little bit more about that, I encourage them to, actually this is a very timely announcement. Tomorrow, Wednesday, July 22nd, tomorrow morning from 9 a.m. to 1 p.m., our Office of Health Equity is having its quarterly meeting with its advisory committee. And so I do know that from looking at the agenda that some further discussion of these grants that the Office of Health Equity is overseeing to try to address COVID response and recovery equity will be discussed in some further detail at our AC meeting, advisory committee meeting tomorrow. So I'm happy to send the link to that meeting for those who might be interested in calling in. It's a meeting that's open to the public. And so I just wanted to call that out as one specific, a practical kind of response that our office has engaged in to try to address part of that, even though to address your initial question, Melissa, I'm not really aware of kind of industry-driven data on COVID impacts in those particular industries, particularly focusing on vulnerable populations.
Okay, thank you.
Other questions from the group? Happy to take them by voice or chat.
Great. And we have a new person who joined us from area code 408.
Eight 70070.
Yeah, be from San Mateo County.
Hello.
Sorry, I was on mute.
Thanks for joining us. Hearing no more questions, thank you so much, Peter, for your presentation. Oh, go ahead.
Sorry, it just takes me a while. Brain is kind of going through like the mud right now, so that's kind of how slow my brain is working nowadays.
Oh yeah, I hear you.
So I think just kind of following up on the last time you presented, Peter. I think one of the things I was thinking of is the state has. I think I was kind of thinking before about like the mapping, right? The state has the statewide data. If you combine all the cases, all the dates, maybe map them, and then determine the social determinants of health information for those block groups, blocks, census tracts, however small you can get it to, and then kind of combine them, and then maybe determine what the which of those tracts that are most affected, and see if are they mostly, of course we already have, especially if we have a lot of missing race ethnicity data, maybe this is something you can then use as just go ahead and map them, and then determine in that block group the block groups that are mostly affected. Are they mostly people of color? What are the languages spoken, and like the poverty level, educational kind of things like that? Is that something that maybe the state is able to do, or you guys, like your group, can do, or maybe you guys have done that already?
Yeah,
I don't know if that made sense, Peter.
absolutely. Yeah, I was just trying to think of something. It rang a bell when you started making that suggestion. So the first thing I thought of is that are you familiar with the California Healthy Places Index? That's the tool. It's a really
Yeah, but
powerful
I'm
data
thinking
tool.
more of like combining them all at once. Yes, those can tell you like in that track what it is, but I'm thinking more of like if you combine them all these, like this is how many, combining all these different tracks together and then kind of really assessing, they make up this many proportion of the state and they're mostly blah, blah. You know what I mean? As opposed to just me looking for Solano, which sometimes is a little bit hard, but then really looking at it statewide and combining all the data together. Does that make sense? As opposed to just track by track, like it really is opposed to just looking at it as a place, really maybe summarizing them.
And that, are you saying that because that will give you a way to kind of compare tracks that have similar characteristics on certain, like the composition of the racial ethnic composition of that particular tract or block?
I guess I was kind of thinking more of a summary of these different, in my head, I'm just kind of thinking out loud as like, these different tracks, if you add up all these, if you look at all these different tracks, I don't know how it would look like if 99% of these tracks have this composition or, yeah, I mean, I don't know how it would look like. I think sometimes for me, it's like I have an idea and then it's like not until I start doing it that I actually kind of, know which route I want to go to. But I'm thinking more of a summary of these different tracks that are mostly either affected compared to those that are less affected.
I see.
Almost kind of like an ecological study, but not quite. Is that what I'm thinking of? It will make sense to me at some point and maybe to you at some point, but just kind of worth thinking of how we can do that.
You're thinking about prevalence, I think.
Oh, not
No?
yeah. Well, of course the cases, right? Like where are they? And then even the deaths, like the deaths, if you map them, in what communities are they mostly? Like 70% of our deaths are from these kind of communities. Maybe that's the way to do it. I don't know if that's how I'm thinking of in terms of summarizing, but almost kind of looking at all the different census tracts where the most affected communities are, and then either combining them or summarizing them.
Similar to the way that was done to look at life expectancy across low income, high, people of color census tracts.
But then combining them together, Melissa, like at the state, I don't know if I'm making sense.
I think it kind of creates a typology of the neighborhood sort of thing. Impacted.
Not the neighborhood, but so it's not necessarily looking at the neighborhood, but combining the data for those neighborhoods together. Or summarizing these neighborhoods are the most affected, and here are their demographics, here are their characteristics of those neighborhoods that are mostly affected. I don't know.
It's my understanding that the HPI, the Healthy Places Index tool that overlays the actual COVID-19 counts across those the geographies that you mentioned, I think gets at that question. But I'm happy to discuss with you separately, Mylene.
It may just be an offline conversation, Peter, because I don't think that HPI is gonna. Yes, it's a tool to help you get to, I think, what I'm thinking of. It's basically putting all those information together and summarizing them. So yeah.
Yeah, can we talk offline about that idea?
Yeah.
A little bit more. Yeah.
Or what are you doing?
And so, again, thank you for everyone's questions and participation. I know everyone's super busy. Appreciate your time and thoughts. I really do encourage you to contact me if you have any other suggestions or concerns about, how CDPH should present its data on COVID-19. I do know that even though that group is very stretched, they are open to, suggestions. And as my understanding is they have been in contact with some jurisdictions, I believe, to try to get kind of more granular data that even though they're not published on the CDPH website. And so if I can be, if I can help connect folks on this call or in your various jurisdictions or, spheres of where you work, and I can try to connect you to the right folks in the CDPH site to try to give you, the best access to data as best as possible. So please contact me with any further comments or questions, and I appreciate your time.
Hi, this is Anandi from Santa Clara County. I just had a question. Are you thinking about any sort of COVID equity index and things like that at a statewide level? Just was curious to know about that, if there have been some thoughts about it.
COVID equity index. Yeah, that certainly would be given, going back to the slide I showed earlier about, well-known, well-documented dimensions of health equity that are associated with COVID. As far as I know, we don't have a CDPH initiative to develop a COVID-19 index. I can ask our science branch just to verify that. Certainly, there seems to be enough data and enough inputs on to develop such an index. Do you have any specific research ideas on that you can share with the group?
Not at this point, but that's something we've been thinking about. Yeah, it's nothing's formulated at this point, but one of the ideas is sort of taking even the social vulnerability index and sort of making some modifications to that as needed and things like that. Yeah. So, but we haven't landed on anything concrete, but just wondering.
Made a note to myself to ask about a COVID index, and if there's some information about that, I can report back to the group. I'll do so.
Yeah, no problem. Yeah, we are trying as much as possible in Santa Clara County to try to fill the data gaps. With the hospitals, we're trying to sort of get a live feed in from the hospitals so that we can, fill some of the data gaps, not just on the positive, but also the negative COVID cases, because we want to understand who's being tested and that the right population is getting tested. That's equal, that's, as important as well. To addressing, the pandemic and, and addressing the equity issues in terms of testing as well. So.
Yeah, absolutely.
I remember now one of the questions that I had when you were presenting, Peter, in terms of the Pacific Islander. Did you say you're not getting as much data on Pacific Islander? Is it or was that in regards to what's shown on the local jurisdictions websites in terms of cases and rates?
Yeah, thanks for picking up on that. I mean, that was my verbal comment, not anything I showed in one of the TBH tables. It was an observation I shared that some of the Bay Area jurisdictions did not have, race ethnicity certifications on their website for. Was that the comment that you're referring to?
Yeah, that may be it. And I think at least for us, we actually do keep that data internally, but because our population is so small, our health officer is, at least for the public consumption, we've actually folded them under for now other, just because, as I said, of our small population, and there may be, for privacy issues basically. And so, but I wonder if that's something that I think would be interesting, but that you guys would be interested in, is looking at it Bay Area wide. I know there's also the Pacific Islander Task Force. As I said, we can provide that to you. And I think maybe some of the other Bay Area counties may also be looking at it more granular level. and they're just maybe not showing it just because of some, of small number issues, right? But that could be something that would be willing to share if that's something of interest that you want to look at.
Okay, thank you, Marlene.
Any last questions before we transition to the next part of our meeting?
No, just appreciation. This was really, really helpful. Thank you.
Yeah, thank you so much, Peter, for taking the time to do this. We really appreciate it, and this is going to go quite a long ways to our membership. So switching gears, we have some time dedicated here to see what we can do to help the public health departments, what you're looking for, and what information would be helpful to hear from BARHII, and where we can use our partnerships and connections to ask for. We also have two kind of asks for you to see if something might be of interest to you, or that could be helpful to us in our policy committee as well as our policies. So we'll start with there. Our policy committee has asked us to check in with the data committee to see if there's any intention or if it's being discussed to compile outbreak data by types of workplaces, particularly across the Bay. We're looking really about essential workers and trying to figure out where outbreaks have been most common so we can kind of focus those efforts. Is that something that the counties might be able to provide, or that the group might be interested in working on?
So this is Mylene, and that is something, of course, we'd be willing to provide. Melanie, however, I think sometimes, I don't know what other counties are using as their outbreak definition, right? I know there's a state outbreak definition. I actually don't know if we're using that definition or not, but at least we kind of have our own. And then unfortunately, we are not able to respond to all outbreaks. Right now, we have about 11 outbreaks at like facilities for elderly, and that's all we can take. And so I think, yes, we'd be willing to share them, but I think it would be incomplete because not everyone is investigated by us, and not everything is determined as an outbreak. So it's a little bit difficult. We can tell you how many outbreaks we worked on, but that doesn't give you the full picture. Does that make sense?
Yeah, that does make sense. Go ahead, Melissa.
No, if you understood it, go ahead. I was going to ask a follow-up question.
No, go ahead and ask it, because I feel like more clarity is better than less.
Would it tell us industry? Even if you had slightly different outbreak criteria?
It can tell you industry, but as I mentioned, we don't follow up with all of them. So it's really a matter of having time to also determine which ones are real outbreaks and which ones are not. And yes, there are some that we've worked on. It used to be like, for a while, it was a lot of food processing, industry things that we were having outbreaks. Now it's long-term care facilities, but we may have some other restaurants that are having outbreaks that we don't follow up on just because we don't have that capacity. And so I think it's just really a matter of our capacity to, one, investigate, and two, to keep up with like the list of the facilities that are having quote unquote outbreaks, even if we don't fully investigate it.
Mm-hmm. So you might have a rough sketch with incomplete data, basically.
Either a rough sketch, or we get notified of a restaurant that has 2 cases, or 3 cases, which could be considered an outbreak, but we don't follow up on it, so we don't have records, and then we don't keep a tally of this restaurant. This is how many we have as quote unquote outbreaks, even though we don't investigate. So it's incomplete, yes, not just incomplete data, but just also incomplete maybe numbers or industries.
Mm-hmm. And if we had, say, a consultant who could help compile things across the region, it would help with compiling across the region, but it wouldn't solve that problem, which sounds like it's a capacity for contact tracing
Right.
and follow-up
Unless,
problem.
yeah, unless they can come and go through our emails here
Right, which they
with
couldn't
us,
do for
then
all
they
9
can.
counties.
Exactly.
Right.
Because right now I think we have, because we do have a common email, and it's almost a full time for me just to go through those emails and give it to the investigators here. So yeah.
And even if they could do that, would it be legal to do that HIPAA-wise? Would that be okay?
That I don't know. They may have to go through like some sort of a volunteer thing with us. I don't really know.
Any other thoughts from other folks on the phone?
And I think just to give some context around why we ask is that it'll help us really target our work, especially in our COVID response platform. We have worker protections as one of our main key priorities, and knowing what industries and areas to focus on would really help us solidify that and get some more clarity.
Yeah, and I have a feeling that maybe instead of getting that from outbreaks, right, Melanie, it can then just be from cases, right? If we have, because I think that's something that is asked, is where do you work? And so if we can just get that from those cases, I know it's not as easy, and I believe, I don't know, Peter, if you've had a chance to look at those CalConnect or CalReady data, but you know, the place of occupation is there. So maybe just determining the places of occupation as opposed to outbreaks, because then it's the same thing anyway, right? Because then if you have the cases and where they work, then understanding the outbreaks is almost like secondary data, because now you have the primary information. So it's really understanding where the cases work.
Sense. That sounds like a lot of data to compile, but it does make sense. Any other thoughts from anyone else?
No, that's really helpful feedback, Mylene.
Yeah, and Emily, I don't know if and between Emily and Peter, I don't know which ones of you have worked with like the CalReady data. It sounds like at least when you're presented, Peter, with the case with the race, ethnicity, and age. I don't know if either of you have had a chance to look at the full data set from CalReady and how populated that information is in terms of occupation or places of work.
I have not seen the full data set.
Okay, got it. But would you have access to it though, Emily?
Sort of.
I'm gonna start a shift at the RCCC later this week, so I might. I'm not sure right now.
Okay, thank you.
Okay, switching to our next ask. Melissa, I think you had briefly mentioned it already, but I know you had a specific ask around contact tracing from the counties.
Yeah, so we had our last executive committee meeting and we got some details about anecdotally things that people have started seeing in terms of cases, what has happened after cases, when people have quarantined and when they haven't. And it was a really helpful anecdotal conversation about what the policy solutions might be for what kind of cash assistance in particular might be needed in the undocumented community and for farm workers. And it made me think that actually getting more of the anecdotal information that's coming from contact tracing in an ongoing way could be really helpful for the region to respond to trends and patterns. And I'm wondering if there's a way to set up a system that would allow us to do that. That's relatively simple. We do have some resources to bring in a consultant if that's helpful, to collect stories that you're hearing, that seem to be trends across the counties and can identify, that person could identify some trends across the counties. So I'm wondering if people have any thoughts on what a process like that could be. You're on, you're not on mute. If anyone has a sense of what those trends might be, or not trends, but what the process could be for doing something like that. And think, if you're not sure, but you could help us think out loud about it, that would be good. What might be possible, what might not be possible.
Any thoughts from the group?
Sorry, what was the question, Melissa? I was kind of distracted a little bit with an email.
I'm trying to figure out if we can get more information that's coming anecdotally and through contact tracing to help inform our policy positions about what's needed, particularly for the communities who are most impacted. And we have some consultant resources we could apply to it if we could think about how.
Okay.
Maybe we'll think about it a little bit more with you offline, Mylene.
Yeah.
Which brings us to the kind of the next step, which is the opposite question.
Oh, I thought I was unmuted, but I was muted. But go ahead. Let's move on, because I don't know if my answer or what I'm thinking of is what Melissa is asking.
Okay, maybe we can just talk afterwards, Mylene. We'll find time.
Yeah,
Not right after.
I have a call after this at 4 o'clock. I have actually 2 calls after this, but yes.
Okay. Yeah, just give me a ring on my cell.
Okay.
Thank you all for helping us think through some of these things, and we will continue to think on them and try and figure out where we can and how we can get the data to better further our policies. Now, flipping it around, that's what we would love from you to help BARHII. What can BARHII do to help you? Is there any information we can help you track down, or using our partnerships to get connections with whoever we need? We would like to be of assistance to you just as much as you've been of assistance to us. So is there any asks from the counties or issues you're having that BARHII can assist with? How about, is there any presentations or people we could bring in to speak on issues? Is there specific speakers that would be helpful for us to reach out to and try and get, or specific topics you'd like covered around COVID or other data?
Working through all the mud in my brain. I'll I'll at least email you if I come up with something, Melanie.
Thanks, Mylene. Any other thoughts from anyone else?
Are you all interested in different ways testing is happening to increase access for people? Or are you more interested in what happens once the testing is in? I see a few people still on the line. Emily, Danny, Wee Long. I'm not sure who is Gold, maybe? Not sure who that one is. Mylene, you went on and off on your mic.
Oh, I did. No, I may just be playing with my computer right now.
Okay. Well, we can follow up with you. We will be following up with everyone following this meeting. That's a lot of followings. Peter is going to be getting us the information as well as the PowerPoints and the resources he promised, as well as answers to the questions posed by the group. We'll make sure to get that information out as soon as we get it. We'll also send out the recording of this Peter's presentation, as well as the specifically linked to the resources in the slides. In that email, we'll follow up with you again about the same things we asked about in this at this end conversation about whether there's data that we could do to help you or future presentations you'd like to hear. Thank you everyone for coming today. Our next meeting is next month, third Tuesday as always. We have San Francisco lined up to speak. Not quite sure what they're speaking on yet. I'm following up with them today, but I will keep you posted. Other than that, we'll also have an outside speaker that we're still working to confirm. So thank you everyone for being here today. Happy Tuesday, and hope you have a wonderful rest of your afternoon.
Thanks, Melanie.
Thank you, Melanie.
Thank you.